Hello, my name is Bronnikova Alina and I'm a medical doctor as well as member of the Medical Advisory Board MDNexa. Today I will discuss sepsis as both a biological syndrome and a global clinical challenge. Sepsis is not simply infection, and it is not the same thing as bacteremia. A patient can have an infection without sepsis, and a patient can have sepsis without positive blood cultures. The central problem in sepsis is not just pathogen, it is the host response. Modern sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. That definition matters clinically because it explains why treatment is not only about antibiotics. Management also requires hemodynamic support, source control, monitoring of organ dysfunction, and adaptation to the local healthcare setting. In this presentation, I will compare the pathophysiology of sepsis and the major guideline approaches across the surviving sepsis campaign, Europe, the United Kingdom, Australia, the Gulf region, and the Mediterranean. The definition of sepsis has changed substantially over time. In 1991, the American College of Chest Physicians and the Society of Critical Care Medicine defined sepsis using the systemic inflammatory response syndrome in the context of suspected infection. This included fever or hypothermia, tachycardia, tachypnea, and white blood cell abnormalities. The strength of the systemic inflammatory response syndrome criteria was high sensitivity. They helped clinicians catch patients early. However, the weakness was poor specificity. Many hospitalized or intensive care patients meet these criteria without actually having sepsis. In 2001, the definition expanded and introduced the term severe sepsis. Then, in 2016, the third international consensus definitions for sepsis and septic shock, known as Sepsis 3, changed the focus. Sepsis became defined by organ dysfunction caused by a dysregulated host response to infection. The sequential organ failure assessment score became central. A rise of 2 or more points suggests clinically relevant organ dysfunction. The term severe sepsis was removed because sepsis itself is already life-threatening. The ongoing debate is that Sepsis 3 is more specific, but it may miss early, typical or resource-limited presentations if clinicians wait for obvious organ failure before acting. Pathophysiologically, sepsis is a disorder of immune dysregulation. The first phase is often hyperinflammation. Pattern recognition receptors, including Toll-like receptors and NOD-like receptors, recognize pathogen-associated molecular patterns and damage-associated molecular patterns. This activates macrophages, neutrophils, complement, and endothelial cells. The inflammatory response includes mediators such as tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and interleukin-8. This is the classical cytokine storm concept. But sepsis is not only excessive inflammation. Many patients also develop immune paralysis. This includes T-cell apoptosis, monocyte deactivation, and upregulation of programmed cell death protein 1 and programmed death ligand 1. This immunosuppressive phase helps explain secondary infections, reactivation of latent viruses, and persistent organ dysfunction. Organ injury is therefore multifactorial. The cardiovascular system develops vasodilation, reduced systemic vascular resistance, and myocardial depression. The kidneys develop sepsis-associated acute kidney injury. The liver may show cholestasis, impaired synthetic function, and impaired lactate clearance. The brain may develop sepsis-associated encephalopathy due to inflammation, microvascular dysfunction, and blood-brain barrier disruption. The transition from local infection to systemic collapse is driven largely by the microcirculation and coagulation system. The endothelium becomes activated and injured. The endothelial glycocalyx is damaged, capillary permeability increases, and fluid leaks into the interstitial space. This creates the clinical paradox of septic shock. The patient may be edematous or fluid overloaded while the tissues are still underperfused. At the same time, coagulation becomes dysregulated. Tissue factor expression activates the extrinsic coagulation pathway. Microthrombi form in the microcirculation, while fibrinolysis is impaired. In severe cases, this can progress to disseminated intravascular coagulation. So sepsis is not simply low blood pressure. It is vasodilation, capillary leak, endothelial injury, microvascular thrombosis, mitochondrial dysfunction, and impaired oxygen utilization. This is why restoring blood pressure alone does not always mean restoring tissue perfusion. A patient can have an acceptable mean arterial pressure and still have ongoing microcirculatory failure. The shift from older definitions to sepsis 3 changed clinical thinking. The older systemic inflammatory response syndrome approach was simple and sensitive. It was useful for early recognition, especially outside the intensive care units. But it was not specific. Many patients with trauma, pancreatitis, surgery, burns, or non-infectious inflammation can meet those criteria. Sepsis 3 made organ dysfunction the defining feature. The sequential organ failure assessment score was used to operationalize this. Septic shock was also defined more strictly. The patient requires vasopressors to maintain a mean arterial pressure of at least 65 millimeters of mercury and has a lactate above 2 millimoles per liter despite adequate fluid treatment. The quick sequential organ failure assessment score was introduced as a bedside risk tool. It includes altered mental state, respiratory rate of 22 or more, and systolic blood pressure of 100 millimeters of mercury or less. However, quick sequential organ failure assessment should not be used only to rule out sepsis, alone to rule out sepsis. Its strength is simplicity and prognostic value. Its weakness is lower sensitivity for early sepsis, especially in emergency department and non-intensive care settings. The practical point is simple. Scoring systems support clinical judgment, but they do not replace it. The Surviving Sepsis campaign remains the leading international framework for adult sepsis and septic shock management. The 2026 update moves away from a rigid one-size-fits-all Hour 1 bundle. Instead, it emphasizes rapid recognition, early source control, individualized resuscitation, and antibiotic timing based on the probability of sepsis and the presence or absence of shock. Lactate should be measured early in suspected sepsis or septic shock. If lactate is elevated or if shock persists, serial lactate measurements are useful. But lactate should not be treated as a command to give unlimited fluid until it normalizes. It is a marker of risk and perfusion, not a perfect measurement of tissue hypoxia. Blood cultures should be obtained as soon as possible, ideally before antimicrobials, but only if this does not delay treatment. For antimicrobials, the key concept is risk stratification. In septic shock or in probable or definite sepsis, antimicrobials should be given immediately, ideally within 1 hour. In possible sepsis without shock, clinicians should perform rapid assessment and investigation and give antimicrobials within 3 hours if concern for infection persists. For fluids, the Surviving Sepsis Campaign 2026 suggests at least 30 milliliters per kilogram of intravenous crystalloid within the first 3 hours for sepsis-induced hyperperfusion or septic shock. This is not a blind mandate. The patient must be reassessed frequently for fluid responsiveness and signs of overload. For vasopressors, norepinephrine is a first-line agent. The initial target is a mean arterial pressure of at least 65 millimeters of mercury. If shock is unstable, vasopressors may be started early including through a peripheral line if needed, rather than delaying treatment until central venous access is available. Europe broadly accepts Sepsis 3 and the surviving sepsis campaign framework, but European practice is not uniform. Germany, through the German Sepsis Society, places strong emphasis on awareness, early recognition, early source control, coding reform, and quality improvement. Public campaigns such as Deutschland erkennt Sepsis, meaning Germany recognizes sepsis, aim to improve recognition outside intensive care settings. France and several European intensive care traditions often favor a more restrictive fluid strategy and earlier vasopressor use. This reflects a hemodynamic philosophy in which persistent hypertension is not always treated with repeated fluid boluses alone. The European Society of Intensive Care Medicine co-authors the Surviving Sepsis campaign, but European practice often emphasizes individualized resuscitation. This includes dynamic fluid responsiveness, assessment such as passive leg raise testing, pulse pressure variation, and echocardiography. The clinical message is that not every patient with septic shock benefits from repeated fluids. Some patients are fluid responsive. Others need earlier norepinephrine, source control, and careful monitoring to avoid fluid overload. The United Kingdom approach is important because it separates the official national guideline from the bedside implementation tool. The current adult United Kingdom guideline is the National Institute for Health and Care Excellence Guideline number 253. This applies to adults aged 16 and over with suspected sepsis who are not pregnant and have not recently been pregnant. The Sepsis 6, developed by the United Kingdom Sepsis Trust, is a practical bedside implementation tool. It includes oxygen if required to maintain target saturations, blood cultures, intravenous antibiotics, intravenous fluid resuscitation if indicated, measurement of serum lactate and full blood count, and monitoring of urine output. But the Sepsis 6 is not the same thing as the official National Institute for Health and Care Excellence Adult Guideline. National Institute for Health and Care Excellence Guideline 253 uses National Early Warning Score 2 risk stratification and clinical judgment. High-risk adults should receive urgent assessment, lactate measurement, blood cultures, source investigation, broad-spectrum intravenous antibiotics within 1 hour, and fluid resuscitation if indicated. Moderate-risk adults may undergo further diagnostic clarification, and antibiotics may be deferred for up to 3 hours if appropriate. Low-risk patients require monitoring, safety netting, and reassessment. So the United Kingdom model is not do everything for everyone. It is risk-based escalation. Australia shows how sepsis care must adapt to geography, healthcare systems, and equity. In Australia, sepsis care should be framed around the Australian Sepsis Clinical Care Standard 2022. This standard focuses on early recognition, coordinated best practice care, timely escalation, appropriate treatment, follow-up, and reducing the risk of death or long-term morbidity. This matters because Australia has a major geographical variation in access to care. A patient in a tertiary metropolitan intensive care unit is not in the same situation as a patient in a remote rural hospital without an on-site intensivist. For that reason, telehealth intensive care, retrieval medicine, early escalation pathways, and local protocols become central. The guideline has to work not only in a major hospital, but also in remote and resource-limited settings. The equity dimension is also essential. Aboriginal and Torres Strait Islander peoples experience a disproportionately high sepsis burden and worse outcomes. This is influenced by comorbidities, delayed presentation, access barriers, and culturally unsafe healthcare environments. So in Australia, sepsis care is not only a critical care problem, it is also a systems problem and a health equity problem. The Gulf Cooperation Council region has a different sepsis context. The Gulf Cooperation Council includes Saudi Arabia, the United Arab Emirates, Kuwait, Qatar, Bahrain, and Oman. Many tertiary centers in the region are highly advanced, but the region has specific challenges that affect sepsis presentation and management. Extreme heat and dehydration may complicate hemodynamic assessment. Patients may arrive with heat-related illness, volume depletion, infection, or a combination of these. Lactate interpretation can also be complicated because lactate is not specific for tissue hypoxia. It may be elevated due to hypoperfusion, impaired clearance, adrenergic stress, seizures, liver dysfunction, or other metabolic causes. Delayed presentation may also occur. Some patients may rely first on primary care, traditional medicine, or may delay emergency department attendance. As a result, patients may present after the ideal early recognition window has already passed with established organ dysfunction. Antimicrobial resistance is another key issue. Empirical antibiotics should not simply be copied from international guidelines. They need to reflect local antibiograms, prior colonization, infection source, severity of illness, and antimicrobial stewardship policies. In other words, international guidelines define the principles, but local microbiology determines the safest empirical antibiotic strategy: fluid resuscitation. But lactate is not a perfect marker of tissues hypoxia. It can rise from adrenergic stress, beta agonists, seizures, liver dysfunction, impaired clearance, or mitochondrial dysfunction. This is why lactate trends are often more informative than a single value. Second, corticosteroids. The Surviving Sepsis Campaign 2026 suggests intravenous corticosteroids for adults with septic shock. However, practice varies because trial results have not been completely uniform. The trial, which stands for Activated Protein C and Corticosteroids for Human Septic Shock, showed mortality benefit with hydrocortisone plus fludrocortisone. The Adrenal trial, which stands for Adjunctive Corticosteroid Treatment in Critically 3 patients with septic shock, showed faster shock resolution with hydrocortisone, but not the same mortality benefit. Third, source control. Antibiotics alone may fail if the source remains active. Abscess drainage, surgery for perforation, removal of infected devices, or debridement of necrotic tissue may be the decisive intervention. The Surviving Sepsis Campaign 2026 suggests source control as soon as practical, ideally within 6 hours, when an anatomical source requiring intervention is identified. So, what does the evidence actually say? There is strong agreement that early recognition matters, especially in septic shock. There is also strong agreement on early effective antimicrobials, source control, hemodynamic support, culture-guided de-escalation, and norepinephrine as the first-line vasopressor. Balanced crystalloids are generally preferred or suggested over 90% saline when appropriate, but the magnitude of over 0.9% saline when appropriate, but the magnitude of benefit varies between trials and populations. Several evidence gaps remain. The optimal fluid volume and endpoint remain unresolved. The classic trial, meaning conservative versus liberal approach to fluid therapy of septic shock in intensive care, compared restrictive and standard fluid approaches after initial resuscitation. The timing and role of vasopressin remain debated. The VANISH trial, meaning vasopressin versus norepinephrine as initial therapy in septic shock, did not fully settle this question. Steroid benefit remains debated because approach and adrenal gave different signals. Quick sequential organ failure assessment has lower sensitivity than older screening tools in some non-intensive care settings. And finally, many landmark sepsis trials were performed in high-income Western hospital systems. This limits generalizability to the Gulf region, Mediterranean settings with high antimicrobial resistance, rural areas, and local resource environments. So the conclusion is not that guidelines are useless. The conclusion is that guidelines should guide clinical judgment and not replace it. The main takeaway is that sepsis care must be evidence-based but also context-aware. Pathophysiology matters because it explains why patients deteriorate. Sepsis involves immune dysregulation, endothelial injury, microvascular thrombosis, vasodilation, capillary leak, mitochondrial dysfunction, and organ failure. Guidelines matter because they standardize early action and reduce harmful delays. But context also matters. Antimicrobial resistance, climate, mortality, intensive care capacity, culture, health equity, and resource availability all shape how sepsis care is delivered. The future of sepsis care is not simply more protocols. It is smarter protocols, rapid enough for septic shock, cautious enough for diagnostic uncertainty, and flexible enough for different healthcare systems. Sepsis does not respect borders, but the evidence guiding its treatment has often come from a narrow group of hospitals. The next challenge is building global sepsis guidance that is scientifically accurate, clinically practical, equitable, and locally adaptable. Thank you very much for your attention.